Grossman, who is a clinical social worker with Brigham Psychiatric Services at Brigham Women's Hospital, where I practice. She is a Robert Wood Johnson clinical scholar working with an interdisciplinary team at the Brigham on Trauma-Informed Care Initiative in the ED. She's also a member of the Mass General Brigham Trauma-Informed Care Initiative, co-chairing the education committee of that initiative. And she is also the co-chair of the Diversity and Inclusion Committee of Brigham Psychiatric Services and lead for the Collective Action Committee of the Social Work Racial Justice Committee of Brigham Women's Hospital. And I actually got the idea for this podcast after a discussion that I had with my colleague and co-chair Ann Mosenthal and with Dr. David Livingston, our esteemed incoming president, about the importance of trauma-informed care. And I had the good fortune of serendipitously the next day being on a conversation with Samara Grossman talking about this specific topic. And she is a very compelling speaker, and I'm excited for you to hear her. After that, we'll turn it over to Dr. Stephanie Bonne, who I think is well known to many of you. She certainly has a very high profile in social media and has been active in the gun violence minimization program. I don't know why I said that, but that's what I said. Anyway, she is an associate professor of surgery in the Division of Trauma and Critical Care at Rutgers in Newark, and she practices trauma and critical care surgery at University Hospital, where she is the trauma medical director and director of the center's hospital-based violence intervention program. She is also the co-chair of the hospital-based violence intervention work group of the American College of Surgeons Committee on Trauma, as well as on numerous national committees focused on the mitigation of injury and violence, including the AAST Prevention Committee and the COT's Improving Social Determinants to Attenuate Violence, I-SAVE working groups. She is also currently a Robert Wood Johnson clinical scholar. So we have a very esteemed panel with us today, and I'm delighted for them to get started. Samara, I'll turn it over to you.
Thank you. Let me share my screen and start with the slides. Does that look okay? All right, so glad to be with you all on this historic day. We're glad that you chose to participate. Just wanted to give a little shout out to Mass General Brigham, as you heard, for supporting the Trauma-Informed Care Initiative, and to my colleagues, some of whom have been instrumental in bringing trauma-informed care forward at Mass General Brigham and nationally. So
Dr. Grossman, I'm sorry to interrupt. Can you swap displays? Because right now we're seeing the next slide.
Oh, I'm sorry. Yeah, let me.
That's okay.
One sec. Is this better?
Yes.
Yeah. Okay, great. So my objectives today are just to define trauma and adverse childhood experiences, to help you all understand the intersection of trauma, ACEs, and social determinants of health, and start to describe the principles of trauma-informed care. Dr. Bonne will continue that as well. So I'd like to just start with a common language of what is trauma, because our definition of trauma-informed care trauma might be different than the daily use of trauma that you may use. So you can see these concentric circles of individual, interpersonal, and collective trauma. So for purposes today, just briefly, individual trauma would be an event or series of events that cause sort of lasting emotional, social, physical, spiritual damage or effect on someone, and has a deep impact on their psyche, as well as potentially their bodies. And interpersonal trauma would be what you would think of, interpersonal violence, trafficking, gun violence, different ways, hate crimes, different ways that people interact with each other that causes trauma. And importantly for today, we're going to be thinking a little bit deeper about the relevance of collective trauma on individual interpersonal trauma. And you can see these words outside the concentric circles, just helping us broaden our thinking about what trauma could be. collective traumas and different ways that our society kind of impacts either over generations or in one person's life, either through the phobias or the isms, racism, sexism, transphobia, etc. And then more sort of communal or historic events like wars, as we might see in our society, the impact of pandemics, of political upheavals. And for today, I wanted to point out also medical trauma, which isn't always talked about, but is also another way that we want to just think about. Often what we think of outside our doors, like the trauma happens elsewhere, the trauma can also happen inside our doors, not by any purposeful or neglectful, but just the very events that happen to people when we're giving service or giving a procedure, or doing something can cause trauma itself. So we just want to think both about what's happening in our doors and outside our doors. So I just also wanted to point out, you may have already be familiar with the ACEs studies, but we're just going to talk about it a little bit more. What Dr. Nadine Burke-Harris, the first Surgeon General of California, calls a public health crisis hiding in plain sight. So we'll see why if this is new to you. So the CDC and Kaiser Permanente surveyed 17,000 members. These were mostly white middle-class members, but that's a big N, and they saw that there was quite a bit of adverse childhood experiences in people's past, maybe more than we would normally think. So that includes abuse, neglect, household challenges like having a parent in prison or experiencing mental illness. And they found 2/3 of those surveyed experienced at least one event. And then they also look not only at just, oh, what happened in the past, but what's happening to their bodies. What happens to someone when they've experienced these events? And you can see down here, the more ACEs that one has, the more likely people are to be in poor health. So you see these are liver disease and COPD. But our next slide from a more recent study, 2016, 49,000, and you can see that there's also impact not only in what you might think of in terms of maybe depression or behaviors like binge drinking, but diabetes, MI, CHD, and stroke. And then in November 2019, the CDC put out vital signs, and within it, we could see that addressing ACEs, so they just sort of did the inverse. If you could prevent ACEs, you could also prevent negative outcomes in adulthood in terms of health conditions. So you can see these listed up top, everything from kidney disease to cancer, diabetes, asthma, can have an impact. And that's not only health risk behaviors, but socioeconomic challenges, but actual health itself. So I want to go on an even deeper dive to look at ACEs, because I think it's important when we think about those concentric circles about who's experiencing ACEs, who's experiencing these types of childhood traumas that impact their health so heavily. So we saw that 61% of at least one type of ACE, but who has 4 or more ACEs? Women, Native Americans, Black people, and other racial ethnic groups are more likely to experience more ACEs than males and whites. And the higher the ACEs, you can also see in multiracial and bisexual respondents. So to me, this paints an interesting picture about what's going on in our community, in our society. And then if we just think about it this way, the leaves of the tree might be the more obvious ACEs, things that you can just ask about and get an answer. But the roots move into community and into history and into structural issues. And we can't really look at one, we can't look at just the individual without looking deeper at the roots of what's happening. So there you say things like poverty, discrimination, violence, poor housing quality. And I would say underneath these roots is the waters of racial injustice or the waters of discrimination that are really feeding these roots and flourishing into this kind of negative impact of ACEs on people's health.
Samara, before you go on, there's been a request to increase the volume. So I don't know if you can increase the volume on your computer, if that would do anything.
You can try. I will just try to talk louder. I'm sorry for that. My computer. So when we think about who is on the operating table, we want to think about who has these ACEs, who has these traumas, and who are the people that we're seeing. Because some ways we may take some guesses or make some assumptions about who the patient is. We may not know much about them. We certainly don't get always a chance to ask them, nor should we, about their histories, their ACEs, their trauma scores. But we might want to start to think about who they are and what complexities of identity they're bringing. And this idea of intersectionality, in other words, that we all have multiple identities, comes from Kimberly Crenshaw, who was looking at the impact of identities and oppression. So when we think about who's on the operating table, I just want to give a couple of examples. This, I'm sure, is very familiar data to you. But just when you think about it, so 1 in 7 women and 1 in 18 men are severely injured by intimate partners in their lifetime. So maybe they're coming to you, maybe they're on your table because of an injury based on what's happened to them. But maybe it's something that's happened to them in their past, and they're carrying those high ACEs, and they're carrying those trauma scores that are high, and it's bringing them to your table, and it might be impacting their care. Also, when we look at risk for serious violence across race and ethnic groups, you can see that there's also a trend. There's something going on. And there's a quote from the people who put together this study saying that for the past 4 decades, the rates for Black and Latinx or Hispanic populations have remained steady. So that isn't changing over 4 decades. 1.8, 1.4 higher relative risk. And when we look at multiple races, again, we see 4.1. When we look at Native American, we see 2.4. So we need to start to really think deeper about who is showing up and what kind of trauma are they carrying. And when you think about that ACEs tree, not only their individual traumas, not only their one person story, but those 4 decades of risk for violence and what's happening on those roots, what's happening under those roots that's feeding that water that might cause people to have traumas in their lifetime that might have also been happening over decades or over history. So then that leads us to think about racism itself in healthcare and what we might be accountable for. And I just wanted to share this information from the Institute of Medicine, which I know is a little bit old, but I feel like it's still quite relevant. And it says across virtually every therapeutic intervention, from high technology procedures like yours to basic forms of treatment, Black people and others in BIPOC communities receive fewer procedures and poor quality medical care than whites. And those differences persist after statistical adjustment for variations in health insurance, in social economic status, in stage and severity of disease, in co-occurring illness, and even the type of healthcare facility has been taken into account. So this isn't a one-off, this is what's happening. So this is all to say, this is how we need to think about trauma-informed care, because we want to be accountable. We want to think about how can what we do re-traumatize, again, not by intention or not by neglect, but just by the very state of what's been happening. So when we think about personal, cultural, and historic trauma, we have to take that into account to think about how is our care showing up? Is there bias? Is there fear of bias? Or is there actual bias? And then when we think about what it means to a patient to come to see us, and just looking at this picture, for them, it means a lack of privacy. It means procedures that aren't routine for them, although they might be very routine for us. It could be just the mere fact of being touched by another or taking off their clothes, getting to vulnerable physical positions. And for those that might go under anesthesia, there is fear about what's said about them, what's done to their body without their awareness, and that sense of feeling vulnerable. Back to that sense of the individual trauma being social, emotional, spiritual, that sense of what does this mean to me to not be able to be conscious? What will I be able to do? So why trauma-informed care? Because those coming to you have had experiences that impact their health, as we saw with ACEs. They have experiences that might impact their care and their sense of recovery. And for patients who've carrying ACEs or trauma, it also means for them a lack of control, that sense of a lack of safety, that they might be feeling more vulnerable than most. And so ACEs and other traumatic experiences impact their health and the ways that they might engage in healthcare. So when I'm training, I often talk about, well, who's that patient that you feel like is difficult to reach? Or when you're talking to them, they seem aggressive or combative or really silent, or they're not showing up for care in ways that you think they should. This is a way to start to understand that it might be because they're feeling unsafe. It might be because they're carrying that individual or interpersonal or community or historic or structural trauma. And for them, that means that they don't feel that as comfortable as maybe they'd like to even, and it's showing up in their behavior. So when we are able to give trauma-informed care, we're able to address trauma on all levels. We're able to address the individual impact of traumas, the interpersonal impact of racism, sexism, other isms, bias, and microaggression, and we're aware of and able to address with understanding and awareness the collective impact of historic, structural, and societal traumas. And in some ways that accountability is trauma-informed care is part of do no harm. And I think Dr. Bonne will get into it in more detail, but it gives us the ability to decrease our stress and burnout. You'll hear about that more. So these are some of my favorite ways to implement quickly trauma-informed care. The most important being safety, that you want to address physical and psychological safety, so that someone that might be carrying ACEs or levels of trauma, that you're able to address that, but we're not saying address it by just asking them and then saying, oh no, I'll make sure I change. You address it from a universal awareness or a universal precaution approach to be like, because ACEs are so high, 62% or more, that I'm just gonna assume that perhaps people aren't feeling that safe when they come in. And how can I work with that? By collaboration and mutuality, by providing trustworthiness or transparency or both. For me, most importantly, looking at empowerment, voice, and choice, so that I'm giving some sense of control, even if it's small, back to the patient. And from cultural, historic, and gender acknowledgement, I'm really understanding who this patient is from that intersectional approach, from that roots and that leaves approach, from the collective, interpersonal, and individual approach, that I'm seeing someone in their complexity, even if I never have a chance to ask them every last history. So in some ways, trauma-informed care has a guiding question. It's sort of a call to action, I've always thought of it, about how willing are we to change ourselves so that we can give this kind of approach to giving safety? And how can we change the system and the culture that we're in? Because it's really hard to do just one provider at a time. It is a cultural change. And trauma-informed care has these protocols which come from SAMHSA, which realize that there is widespread impact of trauma. So the ACEs data I gave you recognizes how individuals involved in an organization, the patients, the workforce, we're all affected by trauma. And we can't just say it's the them issue, because if ACEs is 62%, ACEs is us. And responds by integrating knowledge about trauma into policies, procedures, and practices. So again, this doesn't mean asking the patient and putting the burden on the patient. You tell me about your trauma and I'll try to fix my care. We try to say, what do we need to do to change so that we can encourage everyone here, wherever here is, to feel safer, to feel empowered, to feel that there's a collaborative approach to care, to feel that their provider, whoever they might be, is trustworthy and transparent about what's happening. And to me, most importantly, it resists re-traumatization. So that if we're aware that there's different levels of trauma, they're aware that we have an ability then to resist the levels of re-traumatization that could occur. So trauma-informed care in a nutshell switches from what not everyone would say, oh, this isn't how I practice, but the traditional what's wrong with you, perhaps a deficit model, to what has happened to you, or how has what happened to you affected you, using the 6 tenets and using universal awareness. And I like to move it forward a little bit to say not only what has happened, but what is happening in the room. And then thinking even a little forward, what am I going to do to make sure that I'm accountable to address trauma in the future? So when we're in the room, we're thinking about what trauma could be here now in terms of power differential, bias, microaggressions, and how can I be responsible to address that by using the 6 tenets? And what can I do to move my agency or my group or my clinic forward so that we're really being accountable to all types of trauma? So that's all I have for this section. Thank you, and I'll turn it over to Dr. Bonne.
Thank you. Thank you for the kind introduction and for the AAST for the opportunity to present this very interesting topic, very timely and I think relevant to what's happening in the trauma world and the trauma community as well as our world right now. So as was stated, trauma-informed care shifts the focus away from this question of what's wrong with you to this question of what happened to you or what is happening to you right now. And that's, I think, really important key tenet to sort of change the way that you think about this. So the first topic I'm going to talk about is toxic stress, intergenerational trauma, and epigenetics. So what is toxic stress? So trauma triggers this pattern of biological, cognitive, emotional, and behavioral responses. The fight or flight response is triggered when a threat to self is encountered. The body has a natural process for turning off certain body and brain functions and turning on others in order for us to be prepared to fight or flight or prepare to stay and fight. When the heart rate turns up, we have all of the whole systems activated that we're well aware of in the trauma surgical world. We know this reaction well. But when the fear stimulus is no longer present, the body should automatically regulate and return to its normal state. For youth in particular, and really all people who are exposed to repeated frightening, dangerous situations, people and places that they find frightening or non-safe, their fear response never really shuts down. And so they're kind of functioning all the time in this low-level state of panic, physiologic panic, because there's never a consistency of safety in their life. This causes a shift in a number of their body processes. So if the safety part never happens or isn't consistent, you end up in this constant state of stress. And that's where you get toxic stress. So toxic stress is the hyper activated stress response and results from the body stress response without the balance of any supportive relationships or any buffers to the stress that people are experiencing in their lives. A lot of neuroscience work has been done in this space and has found that when this is encountered in early development, it greatly impacts both brain development, psychosocial development, as well as the metabolic systems. It has a profound impact on learning, behavior, and the development of ultimately stress-related physical and mental illness. So why do individuals experience trauma? Well, we know that there's trauma that we experience in our lives, some of the things that were talked about, physical and emotional stresses in the person's life. And so considering that the patients that come to us in the trauma bay may have had previous life experiences that mimic the trauma bay or mimic that stress response is pretty intuitive to just expect that that's happened before. You never really know what people have been through in their lives. But even for people who haven't experienced direct trauma or direct trauma in their own life in that way, or a constant level of toxic stress in their own life, there's still historic trauma and transgenerational trauma. And this is the trauma that's passed down from generations. And this is basically the cumulative emotional and psychological wounding of individuals or generations of individuals caused by traumatic experiences or events to the groups of people that they identify with. So this is typically the children and grandchildren and subsequent generations of people who were witnesses to war, genocide, slavery, and all kinds of really horrible things. This is really well described in some of the books that I have listed here. Carrying the Historical Trauma of the Lakota by Maria Yellowhorse Braveheart, Post-Traumatic Slave Syndrome by Joy DeGray, It Didn't Start With You by Mark Wolin, and a lot of the work that's been done on PTSD across the lifespan by Rachel Yehuda in New York, who has described the experiences of PTSD in the subsequent generations of individuals who survived the Holocaust. There's also, this is also really well described in this book, Cellular Molecular Mechanisms of Epigenetic Evolutionary Biology, if you are interested in reading more. So what happens is you have this trauma or stressor and you get changes to the epigenome. So you may not have changes to the actual structural genome, but these changes happen in the form of DNA methylation, changes to histones, covalent modifications, or genomic imprinting on the epigenome. So creates variable expression of different aspects of the genome. The mutation rates of the epigenome are much faster, so it's very easy to create epigenetic changes in a population. But the good news is that they're also more easily reversible, these biological changes. So what we've discovered is that some of these biological changes are actually passed down through generations. And then what you have is these different endophenotypes of individuals, some of whom have risk genotypes and some who have protective genotypes. And we all have a mix of risk and protective genotypes, just the same way that we all have a risk of lots of different genotypes in our genome. And these epigenetic mechanisms are at work in the generations that came before us. And when trauma happens and causes variable expression of these risk and protective genotypes, you end up with these vulnerability or resilient endophenotypes. And you can get increased risk of things like PTSD and stress in people who maybe didn't have a lot of stress growing up in their childhood, but a single stressful event can cause a huge stress response, like being in the trauma bay, can cause a huge stress response in these individuals that didn't even really have a lot of toxic stress as a child, but it's being passed down to them through the intergenerational stress of the generations that came before them. I'd like to show a quick video if I can. I think this is a really good video that describes what's at work here, and it's just short.
The sweet smell of fruit doesn't normally send rats running, but when researchers paired the orange cherry almondy scent of the chemical acetophenone with a painful electric shock, lab rats quickly learned to fear it. Along the way, extra neurons sprouted in their noses and in the smell processing center of their brains, making them super sensitive to the scent. This result isn't shocking. What is surprising is that the rats' pups and their pups' pups were also startled by the smell of acetophenone and had the same extra neurons as their fathers, despite never having been introduced to either their dads or the fruity scent before. But how could the pups have inherited something that their fathers learned? Basic genetics tells us that only DNA gets passed along to offspring. Characteristics like memories, scars, or giant muscles can't get passed on since acquiring them doesn't alter the genetic code. But it turns out that instilling fear in the rats did trigger genetic changes, not in the DNA sequence itself, but instead in how that code was read and used in the rats' bodies. In every cell, biological machinery constantly translates DNA into the proteins needed to carry out vital processes. Chemical switches attached to the DNA turn genes on or off or up and down, telling the machinery which proteins to produce and in what quantities. These switches, called epigenetic tags, are why a kidney cell looks and acts differently than a skin or nerve cell, even though all three cells have identical DNA. But the switches in any one cell aren't set in stone. Teaching those rats to fear the fruity smell switched one of their smell sensing genes into overdrive. Researchers don't know all the places in the rats' bodies where this switch got flipped, but they know it happened in one key set of cells, the rat's sperm cells, which would one day pass along the tweaked genetic material, making the next generation of rats super sensitive to acetophenone. Rodents aren't the only creatures demonstrating this weird type of inheritance. In Ivakalik, Sweden, boys who suffered through tough winter famines went on to have super healthy sons, with extremely low rates of heart disease and diabetes. And their sons had the same excellent health, living an unbelievable 32 years longer on average than the grandsons of boys who hadn't gone hungry. To be clear, this does not mean that we should start starving our kids for the benefit of future generations. Scientists don't even know yet exactly which switches the Swedish famines flipped. While we have been able to connect specific epigenetic changes to health effects in mice, we're a long way off from being able to make those connections in humans. That may sound like a bummer, but it's mostly because we humans don't live in the well-controlled environment of a laboratory. And for that, we should be grateful.
So hopefully that's like a little brief. It's a little cartoony, but it's a really good sort of basic description of why this is at play in the psychology of the trauma patients that we have. So in particularly when you think about patients who are coming from generations of vulnerable populations, generations that have been dealing with things like racism, slavery, displacement over and over and over again, you have to expect that their stress response is actually genetically programmed to be different than the stress response of people who didn't come from that level of intergenerational trauma. So how do we use this information to create a trauma-informed physician-patient interaction? How can we as physicians do a better job of interacting with our patients in a trauma-informed way? So one of the things that it starts with is something like understanding that patients are not permanently damaged, making it all up, attention seeking, or just a bad kid acting out. These are people who are asking for help, have trauma that is hard to talk about, or are communicating that something is wrong. And there's probably a lot of spaces in your life or in the trauma world where there's some tropes that you maybe have grown up with as a resident or as a student that you heard over time. Things like, here's another person who is just walking grandma home from church when they got shot. Or here is somebody who's just drug seeking, or all of those different things that we talk about, and sort of in our own way, maybe make light of in order to even not deal with ourselves the trauma that we're seeing play out in front of us. But that's, we really have to move away from that if we're going to talk about trauma-informed care. And we really have to think about all of our patients as victims of a really bad set of circumstances. Nobody asks to be in our trauma bay. So if trauma is all about the lack of predictability, a loss of control, a lack of safety, and a negative worldview, then our job as trauma surgeons and as healthcare practitioners is to create an environment in the healthcare setting that contrasts all of these potential negative things. We have to create a space where our patients feel safe, where they feel like they have control, where they feel like the environment is predictable. So what are some practical ways we can do that? We have to ask some of the right questions. It's really important for us to consider the whole person as they're coming to our trauma bay and be aware that our barriers to treatment or barriers to cooperative, our uncooperative patients may actually be a function that that patient doesn't fully understand what's happening. There may be underlying trauma that they're reliving, or there may be underlying reasons why these symptoms of trauma continue to persist in these patients. And this can include things like poverty, housing, economic problems. So our job is to build trust with our patients, provide appropriate screening and assessment in a safe and comfortable environment, identify and discuss those barriers that we see to treatment in our patients, and have really consistent follow-up so that that relationship of trust between the practitioner and the patient is rebuilt. When we think about our interactions with patients, we really need to think about things like our tone of voice, our body language, how to ask the right questions. That's the what happened to you today instead of, what did you do or what's wrong with you. We have to think about timeliness, follow-up, and then ultimately collaboration and advocacy when we think about creating trauma-informed systems. So what is some of this body language? It's things like going to the bedside on rounds and making yourself level to the patient. If you are a patient who's experienced trauma in the past and then a group of doctors comes and descends on you and they're all standing above you, that may trigger a trauma response to another time in that patient's life or not in that patient's life. It's just frightening, and they remember that their epigenetics make them more vulnerable to this, where they have that fear reaction because there's a whole bunch of people standing above them. So things like coming down to eye level and sitting in the bedside chair when you're discussing the patient's plan of care. Things like, some of the stuff is, pretty basic. Like I think most of us learned it in medical school, but we tend to fall away from it over time. Things like asking if it's okay, may I examine you? May I take a look at your, belly? I'm going to draw back your sheet right now. Instead of just going in and sort of ripping off the sheets and examining somebody. The trauma bay especially is a space. We should always be thinking about how is our patient being traumatized right now when they're in the trauma bay, and is there a way that we can mitigate this? So remember how frightening an experience it is to come off of a stretcher onto the table or the stretcher in the trauma bay and have all your clothes torn off, have 20 people standing around you, you're experiencing pain from the IVs going in your arm. So how can there's not much that we can do, right? We have to take care of the patients, but how can we make that interaction more trauma informed? You're going to feel a poke in your arm. There's a lot of people who are going to be in here asking you a lot of questions, but we're trying to take care of you. My name is Dr. Bonne. I'm the trauma doctor here. I'm going to take care of you. Can you tell me what happened to you today? Those are the kinds of interactions that are really, really important in minimizing that. And also, you know, one of the key components of ATLS is the exposure part. Thinking about how you're exposing patients, remaining, trying to protect modesty when it's safe and you're able to do so. And, saying your clothes are going to be taken off now, but really kind of looking around and saying, does everybody that's in that room looking at this, person laying naked on a stretcher really need to be there? Do the police officers need to be there? Do these, other people need to do there? If you're going to do, rectal, vaginal, and other exams that are private, do you really need to have 6 medical students standing behind you while you're doing that? So some of those interactions in the trauma bay we can really modify to make our whole space there more trauma informed. A lack of trauma-informed care will can result in undiagnosed trauma, misdiagnosis, ineffective treatment interventions, creating that cycle of ACEs and repeating that trauma to that patient such that the cycle of ACEs will continue until they're an adult, and creating greater burden on the healthcare system over time. It can also lead to practitioner burnout and increased costs to other systems like educational systems, juvenile justice systems, welfare systems, et cetera. So once you've learned how to interact with your patients one-on-one in a trauma-informed way, how do you take the next step and build a trauma-informed organization? And when we refer to organizations here, we as trauma surgeons are specifically interested in the environment of the hospital and our trauma center, but trauma-informed organizations can really apply to any type of organization. So schools can be trauma-informed, policing and justice agencies can be trauma-informed. Community-based organizations, should be trauma-informed. So any type of organization can really work on learning this and employing these principles to create a trauma-informed environment. So back to those 4 R's, we need to realize that there is a basic realization about what trauma is and how it affects individuals, families, and communities. We need to recognize people who are showing signs and symptoms of this type of trauma. We need to respond by practicing a trauma-informed approach and resist re-traumatization of our patients and our populations. So when you're talking about building a trauma-informed organization, this isn't a checklist. This isn't like a one and done thing. Like we painted the trauma bay and we did this and we did that. It's not like that. This is a fundamental shift in the culture of your entire organization, and it needs to be a top-down organizational approach. So those 4 R's highlight the basics of culture change that an organization must demonstrate in order to say that they are trauma-informed. It's not simply enough to be aware of the trauma, but you have to seek to identify and respond to it in a way that does not re-traumatize the individuals that you're encountering. So in a trauma-informed organization, the staff and the individuals that they're serving, so your staff and your patients, must feel physically safe at all times. They must feel psychologically safe at all times. They must have interpersonal interactions that promote a sense of safety for all. So understanding what might make one person feel safe and another person feel threatened. So sometimes safety can be at odds. So for example, in emergency rooms or various other places, the nurses and the staff might say, well, what would make me feel safe is if we locked all the doors, put all the patients in restraints, did some, had seclusion, and, left all the curtains open all the time so that we could see all the patients. But that's at odds with what the patients are going to feel safe. They're not going to feel safe if they're locked, restrained, and have no privacy during their physical examinations. So sometimes we have to think about what's making all parties feel safe and marrying that together into an approach that works for everybody. The leadership of trauma-informed organizations should be maximizing collaboration and power sharing between patients and families. So it's important to recognize and name that there is power differentials in the hospital between staff, between administrators, and between patients. But you can collaborate as a team to increase the health of your community. So for example, here's some examples of the way hospitals can collaborate to become more trauma informed. You can do very simple things like abolishing special parking privileges or doctors only lounges. You can create self-directed recovery where professionals facilitate recovery sessions between one another. You can direct that all levels of staff and community are involved in every task force, committee, et cetera. So that there's not really a helper-helpee dynamic, but really that everybody is a team and you're building natural connections within your community. There are 10 domains of trauma, and so I'm just going to give of a trauma-informed organizational approach, governance and leadership, policy, physical environment, et cetera. You can see them all written here. I'm going to go just through one example of each one. So one example of trauma-informed governance and leadership is how does the agency's mission and vision statements reflect the commitment of the agency or the organization to trauma-informed care? In policy, how are the staffing policies in your organization ensured and vetted to make sure that they're culturally relevant to the community that you're serving? How does the physical space promote calming and safety? How engagement and involvement, how do people with lived experience in your community have an opportunity to provide feedback to the organization on quality improvement? Is there a way for them to do that? Cross-sector collaboration. Is there a system in place by which your hospital is communicating with partner agencies or community organizations about the delivery of trauma-informed practices in your center? Screening, assessment, and treatment. Is timely trauma-informed screening available to patients? That's a very, sort of simple one. Training and workforce development. How does the hospital address the emotional stress of those who work in the trauma bay? Does your staff have the appropriate support for the things that they're seeing in their day-to-day life? And what strategy does the hospital use to ensure that the staff and patients feel safe and valued? What funding exists for peer support, for example? For financing, and then evaluation. How does the hospital perform a trauma-informed organizational assessment and making sure that their trauma-informed organizational approach is being included in their assessments? So trauma-informed care specifically in the healthcare setting, it involves screening. You have to understand your own history and reactions and how that's going to change the way that you interact with patients, recognizing that there's interprofessional collaboration, understanding the health effects of trauma, and then, really at the base of all of this is patient-centered care, which we should all be striving for all of the time. So one example of trauma-informed recovery in your trauma center is the idea of peer support. So this, again, comes from SAMHSA. Peer support is a flexible approach to building mutual healing relationships. It's not a service model. It's not a top-down model, which tends to disempower people by removing voice and choice by saying, like, you are going to go into XYZ program. Peer counseling creates gets rid of the power dynamic that you have in normal counseling. It is a trust-building shared relationship. So examples of peer support that have been really successful in the past are things like Alcoholics Anonymous, rape crisis centers where former rape victims are there to speak about the experience. And creating peer support both for your staff and for your patients is really important to providing a trauma-informed recovery from the day-to-day that your staff is seeing, and then from the traumatic event that your patients are coming in with. Trauma-informed injury prevention programs typically avoid things like scared straight. So this is, a picture of like a high school before prom, and they, put a car out in front of the high school, and they put one of the high school kids on the windshield, and like, here's the Grim Reaper coming to get the child off of the car. This is not trauma-informed. This is scared straight. And this has been shown time and time and time again to be not effective. Programs that give high school students or children or, quote, at-risk youth tours of trauma bays and morgues. These are not trauma-informed approaches. This is considered the old scared straight kind of approach, which is, number one, not effective, but is also completely at odds with the principles of trauma-informed care. So imagine, for example, that you're giving an at-risk group of children a tour of your trauma bay and telling them what would happen to you if you got shot. And that one of the children in the group raises their hand and says, are we in the trauma bay at University Hospital? And you say yes. And they say, oh, my cousin died here last week. Okay, that's re-traumatization. That's a very clear re-traumatization and is not trauma informed. And because you don't know, you can't just assume that these experiences don't exist in the communities. A much more trauma-informed approach to injury prevention is understanding that there are multiple contributors to violence and injury. And these exist across the spectrum of individual, interpersonal, all the way up to organizational, community, and policy. So this is from a piece that was done by the Committee on Trauma on how to develop hospital-based violence intervention and understanding the risks of social determinants of health on creating a milieu in which people are at risk for becoming a victim of violence, and understanding that violence exists across all of these domains and that you can attenuate these domains. And the Committee on Trauma is actually quite dedicated to this and recently formed the iSave task force, which was mentioned at the beginning. And finally, managing your own stress and trauma. So you can't become a trauma-informed provider unless you're managing your own stress. And the jobs that we do is real, it's stressful. The things that we see sometimes are really terrible, and we've become resilient to them, and we don't maybe always recognize how terrible some of the things that we are seeing are. So a foundation of being a trauma-informed system is making sure that the people who are in this system recognize their own stress and their own reactions so that they don't create a trauma non-informed interaction as an outcry or a reaction to their own personal stress to what's happening in managing a patient. So PTSD-like symptoms can occur when we have repeated exposure to the stress of others, like people who work in a trauma center. This can also be called, compassion fatigue, and really impacts our daily work experiences. We can also experience vicarious trauma, which is, has to do with our worldview and how we experience the world around us. And this is the result of chronic exposure to trauma in the areas that we work with. So you can ask yourself some quick self-reflection questions to make sure that you're managing your own stress. What time of day is your patients less available? How do you cope? How do you cope when you're not at work? And what do you do to take care of yourself? And creating a self-care plan and committing to it and making sure that you're seeing that through is really, really important to making sure that you're able to use your trauma-informed care approach in your organization. I have a few books that I'm just going to leave up here, which are some suggested further reading. And I'm happy to take questions, as I believe Dr. Grossman is as well.
I want to thank both of you so much. Those were excellent, excellent lectures. Really informative, very, very thorough. I'm going to hope that some folks will pop up in the question and answer, but I want to ask each of you if you could briefly describe a scenario to us clinically where, applying the strategy of trauma-informed care has changed a clinician patient interaction that you've either been involved with or that you've witnessed. I'll start with you, Samara.
So one way that applying trauma-informed care has worked is to work in that collaborative nature, which I think you've heard Dr. Bonne talk about. So although I'm in the outpatient setting, working together with a really complex patient with diabetes, multiple experiences coming into the ED to address her A1C levels. And we came together as a care team, and we worked in this transparent, collaborative empowerment voice and choice model, such that she felt really reassured, and over time her use of the ED went down. I think because of our trauma-informed care. So when we were going to talk to her, we would say, I'm going to share this with the team. Is that okay? And she'd always say with relief, yes, that's wonderful. Because most patients feel that sense of siloing when they get their care, that they can talk to me as the social worker, and then they can talk to their PCP over here and their specialist endocrinology over there, and they don't get a chance to really feel that they're seen as that whole person that they are, sort of back to that intersectional view where the patient is carrying a lot of identities, but also carrying a lot of needs at once. So that's one way that I've seen is quite effective, is really using the transparent and collaborative model to address care. So it takes the burden off the patient to try to navigate their own care or be the spokes to the wheel.
Great, thank you. Dr. Bonnie.
So I think, probably many of the people listening know that I am also really involved in hospital-based violence intervention, and recruitment for hospital-based violence intervention programs can sometimes be a little bit difficult. Even when you're using a credible messenger approach, people are very hesitant to agree to anything that sounds like social work, that sounds like that they need help in any way. And I have found that, when I really feel strongly, like I can see that this patient needs this, or feel like it would just be really good for them, and they don't totally understand, what it's about. I think that bedside interaction and making sure that you go in, the power of things like touch, but asking for it, like, may I sit here on the bed with you and talk to you about this for a second, getting eye to eye level, looking into people's eyes. I mean, we just don't do that much. And if you don't notice that you're not doing it, you might not, and really looking and saying, that says, I see you, I'm looking at you, and you're what's important to me right now. And, a lot of this is just, it's humanism, right? But we forget sometimes in the bustle of our day and in the stress of the work that we do to really see our patients. And so I think that, I found that that when we've done trauma-informed care training with our HVIP staff and even with our own trauma staff, we find just a much higher uptake of our all of the programs that we have aimed toward trauma resilience and recovery in our center, like our trauma survivorship clinic and our recovery center. And when we're using these trauma-informed approaches, patients are just much more likely to engage with us.
Thank you. I'll go to the Q&A. The first question is from Teresa Chin. What kind of community organizations have you partnered with? I'll open it up to either of you.
So, here in Newark, we have, in an effort to train our trauma center faculty and residents and some of our staff, we've partnered with our local mental health agency who does that. It's the center at the university, and they have some SAMHSA grants around developing trauma-informed care and doing ACEs education across healthcare providers. So in terms of bringing trauma-informed care training into your center, there probably are people who are doing this in most communities, especially if you're in a bigger city or if you're in a place where there's academic centers. There's probably trauma-informed care training available. You just have to go out and look for it. And then, in terms of for example, our hospital-based violence intervention program works with one of our community response, like street response teams. We work, with a variety of faith-based organizations, and really, as well as some of our justice organizations, to provide not just like trauma-informed trauma care, but some of our resilience and recovery work around adjudicating criminal justice issues and getting people the resources that they need to address social determinants issues like housing and getting them into mental health agencies and things like that. So that's where a lot of our community partner work is happening, is in that recovery period, trying to get people engaged with community-based organizations that have really good, valuable services that can be offered to mitigate a poor social determinant profile.
I guess,
That's great. Samara, go ahead.
yeah, different, similar but different. So I guess as a social worker, I am the person to bring people to the community, but on a different way. We also work, so Mass General Brigham is sort of the umbrella organization for many hospital systems in Massachusetts. And we've been working the trauma-informed care initiative. So our community outreach is sort of to other hospitals that are either interested in or already have trauma-informed care committees or coalitions formed or forming. And we've ended up, the education committee that I co-chair, we end up sort of being a resource or in a sense, peer support to each other, to sort of keep each other's movement and energy and ideas and not reinventing the wheel each time, so that we can sort of further each other's trauma-informed care work within our institutions. So it's not quite the same as community organizations, but I think it's still useful to think about partnering across hospitals to see how you can support each other.
Actually, Samara, that's a great point, because many of us are affiliated with level 1 trauma centers who have relationships with lower level trauma centers, and really are integrally involved in education and helping them set up structures and processes to care for trauma patients. So I think that's very informative. Thank you for sharing that. Another question is, great presentation. Are there any models for reviewing specific cases of trauma-informed care or lack thereof in a group M&M type setting, similar to a periodic departmental ethics M&M?
So not that I'm aware of, but I will say that we do a 3-part training here in Newark for trauma-informed care. The first part is a didactic, so like a lecture similar to this, where you learn about ACEs and the principles of trauma-informed care. The second is a group discussion where we talk about potential situations, and it's a very sort of intimate group discussion about what trauma-informed care is and how trauma affects us as providers. And then the third is like a bedside, it's like a supervised bedside round. So the facilitator for the training goes on trauma rounds and goes into the room, sees how the team interacts with the patient, and then does an immediate debrief afterwards. So comes out of the room and says, here's what I observed, here's what you did well, and here's what you could do better. Let's go to the next patient. And I think that that's a great training model, actually, because that real-time feedback is really important.
Stephanie, can I ask who participates in that?
So when we first brought it in, it was our trauma faculty, our violence intervention specialists, and our physician extender, advanced practice providers. And we've created, it got a little disrupted from COVID, but we deconstructed this and are currently actually working on some studies doing it with the residents. So the didactic portion is given as grand rounds, and then the discussion and the real-time training are done with each group as they're on their trauma rotation for the year.
Great. Thank you. Samara, you were going to say something?
Yeah, just also to think about making sure that trainings that are done are across the entire organization. Because I was just thinking about trainings we've done when we've done the entire clinic, like the Gen Center, which would be just the whole clinic. When we learn and hear from front desk or support staff, the amount of trauma that they're carrying can be very high as the first contact from patients. So I was just thinking about the importance of whenever training is done, if it's trauma-informed, it needs to be from every level across the agency or the clinic.
Right, thank you. We're almost at the hour, so we have just one more question from Thomas Duncan. I'd like to reiterate that evidence shows that the scared straight approach does not work. On another note, I'm wondering how your center handles connecting with patients that are seen and rapidly released from the ED that will truly benefit from a violence interventionist. Dr. Bonne?
Yeah, so this is a really tough call. So it depends on the resource capabilities of your violence intervention program. There are places where there's a lot of investment that have 24/7 violence intervention workers in their emergency department. So those patients are approached right then and there if they're being treated and released from the emergency room. That is like, for many of these programs, which are, they exist, but they're sort of chronically underfunded, that's like a kind of a wish list. In our center, we do a callback the next day, which is not perfect, but at least they're getting some kind of communication from the violence intervention team. And there's some discussion about the emergency room observation space becoming more like ripe for this. So, you know, a patient comes in, they have a firearm injury to their leg. They don't have any, you know, real, you know, vascular or bony injuries. And so you would normally just address the wound and then send the patient home. And instead of sending them home, you put them in OBS with the intention that they're going to see they're going to be introduced into these, this sort of constellation of available violence intervention services the next day. And also sort of gives a little bit of time. You know, we know that the highest risk for retaliatory violence is right in those first couple of hours following an injury. So,
Right. Thank you. We do that as well. Thank you very much. We are at 6:01, so I want to be mindful of the time. I want to thank you both. This was really, really excellent and something that I think many of us are going to refer back to in the future. So I thank you for such a thorough and really thoughtful presentation. Please join us for our next Grand Rounds on January 27th at 5 p.m. Central Time, which is a different time. The topic will be healthcare cost assessment for the acute care surgery leader. It's a matter of perspective. This will be presented by Doctors Martin, Rotundo, Lester, Shearer, and Davis. Thank you and have a great night. And thank you again for your attendance.